Good morning and welcome to ASH 2015. We're in Orlando at the current ASH meeting. My name's Prof Rule, I'm a haematologist in Plymouth, and joining me is my good friend Prof Le Gouill from Nantes in France, and we're going to be discussing what's been seen in mantle cell lymphoma at this meeting. So I'm going to start with Steve, who's had a couple of presentations here. Obviously there's a lot of buzz about new agents, but we must remember that chemotherapy works very well for young patients, and your LyMa trial clearly very important with the maintenance rituximab. So this meeting, there's been some MRD data and some PET data, which is interesting. Do you want to just summarise what you found?
Yeah, we make two analyses based on the interim data that we showed last year at ASH. So as you mentioned, one was about the MRD, and we all know that in mantle cell lymphoma, MRD could play a key role in the future as a prognostic marker. So Mary Callan from Grenoble presented this first result about MRD in the LyMa trial, and she nicely showed that the MRD status before the transplant is a very important prognostic marker, meaning that of course the MRD positive patient do worse than those with MRD negativity status. And we could show that 65% of the patient reach MRD negativity before the transplant with only 4 courses of DAP. And I think the other interesting question about this presentation was the role of the maintenance. As you know, there were a randomization after the transplant between rituximab maintenance or observation. And what we show in this first analysis is that the outcome of the patients is better when they receive the rituximab maintenance regardless of their MRD status. Yeah. So even if you're MRD negative before transplant, it looks like you take benefits to receive a rituximab maintenance, which hasn't been shown before. So they could help the clinicians to take the decision about should I or not change the treatment based on MRD, even if it's too soon to have MRD-driven strategy. And
so that's an interesting point, isn't it? I mean, that implies that the MRD is not that useful at that point. Yeah. Clearly later on it might be, because you might want to do different things.
Yeah, you're right.
So the timing, I mean, when's the optimum time to be looking at MRD?
Well, there are some different opinions about these things. Based on the French trial, the MRD status before transplant is the more important time point. But there are other data about MRD after autologous stem cell end of treatment. But I think it doesn't make too many sense to look at after transplant, because if the patient is still MRD positive after transplant, then he isn't, of course, it's very difficult to change the treatment because you already finished the treatment. So mid-treatment analysis makes a lot of sense, I think.
So do you think going forward you'll do MRD analysis pre-transplant and maybe do something else to make them MRD negative before you transplant?
That could be an option in the future, but it's difficult to build such MRD-driven protocol, at least in the design of a large trial. It's difficult to do so. But I think we have to really think about that.
Yeah, it's clearly very predictive. And tell me about PET scanning then.
Well, this is also a very interesting thing, I believe, because PET scan, we will use PET scan everywhere in every lymphoma entities, but if there is one lymphoma entities where we don't have so many data, this is really mantle cell.
Exactly.
Well, there's no, as far as I know, large perspective trial, and then we analyze the outcome of the patient regarding of the parameters of the PET scan. And I think there are two things we have to summarize what I presented yesterday. Is if you look at the parameter at time of diagnosis, so before any kind of transplant, the SUV max value seems to have a very important prognostic impact on PFS, but also maybe in overall survival. And we found a threshold of 11. If you below 11, you do better than if you have more than 11 SUV max value. It's a first analysis. We need another cohort to confirm these things. So we have to be careful. But this is the first time that we could demonstrate that SUV max or PET scan could have an impact.
So as we discussed, as we were walking here for this discussion, to me that looks just like a surrogate for Ki-67. We know proliferation is probably the most prognostic thing there is. The more proliferative, the higher SUV max you would imagine. So
I agree.
To me that kind of makes sense, and if that stands up, the PET's going to be a far more useful way of discriminating that than Ki-67, which is hugely much easier, very variable, isn't it?
It could be a surrogate marker, but it will not be so easy to demonstrate because Ki-67, when you do the calculation, you do it on on the biopsy.
Yeah, yeah.
And you don't know if the biopsy will be exactly the same that the PET scan analysis, which is a whole body analysis.
But that's why the PET's better.
And that's why the PET is better.
Yeah.
But if we can't demonstrate that there is a clear link, I think it doesn't mean that it's not a surrogate marker.
No, exactly.
No, it's really clear.
But it makes kind of sense that it would be.
It makes a lot of sense. It makes a lot of sense, of course, yeah. And the second thing that we investigate was the decrease of the SUV max value between start of treatment, end of induction, so before the transplant. And then we found a threshold of a delta SUV of 30%. Remember, it's 16 DLBCL, but in mantle cell, it looks like 30% could be the threshold if you look at the decrease of the SUV max. But that's preliminary. Yeah, it's interesting, and we'll have to confirm these things.
So I guess going forward, PET, maybe MRD, maybe are going to.
Yeah, but PET may be an overall survival.
Yeah, maybe direct the way we do things.
Important. Yeah, maybe.
So what about therapeutic things that you've seen here?
Well, I think a very interesting talk this morning, very early, around 7 in the morning. But maybe you want to comment about it.
Yeah, it was very early to be talking. So I presented the randomised data of temsirolimus against Ibrutinib in relapsed refractory mantle cell lymphoma, which showed a huge PFS benefit in the Ibrutinib treated patients, which I get most of us expected that was going to be the case, because none of us believed temsirolimus is a terribly effective drug in mantle cell. I guess one of the surprising things was how good temsirolimus fared in this trial. Normally when you do a trial with these drugs, they're often not as good as the previous studies, but the PFS was over 6 months, which in the temsirolimus arm.
As compared to Ibrutinib?
15.8.
Yeah.
So I mean, miles difference, but that 6.2 is equivalent to Velcade. It's it's better than lenalidomide. So that the comparative arm fared well. So very impressive PFS. No overall survival benefit yet, although the confidence interval. I mean, it wasn't powered on overall survival. And there was crossover. Okay. But it looks like that might translate into overall survival with further follow-up. The most fascinating thing, which actually isn't in the presentation and isn't in the publication, which is out now.
Yeah, I heard about it.
Yeah, is when we looked at the response by prior line of therapy. The thing with Ibrutinib is everybody's happy giving Ibrutinib wherever because it's going to work. So whichever line of therapy you use the drug, you get a response. But what we did is we looked at progression-free survival by line of therapy, and there's a huge difference. If you use Ibrutinib first relapse, that PFS was a flat line at 65% now. It's not going to be a flat line forever, clearly, but that was the first hint that whilst response rates are the same, you get much better PFS if you use it earlier. So that's telling us really that's a drug we should be using earlier in relapse, and I guess
first relapse, you mean?
First relapse, yeah, and obviously that leads on to frontline, and of course we've got a study that's just starting in the UK looking at frontline. So that's telling us this drug really is robust, and we need to use it earlier on. The other thing that was, again, maybe a surprise because a lot of us have had experience with Ibrutinib, and when patients fail, it's often difficult to retreat. Yeah. In this trial, I think basically because the patients were treated earlier. You could rescue just as many patients with Ibrutinib as you could with temsirolimus. So I guess that gives us a bit more reassurance that using it early isn't going to be detrimental.
What was the follow-up?
Follow-up's 20 months, so it's pretty robust, and the overall PFS slightly better than previous Ibrutinib studies. Again, probably reflecting the fact that we're treating patients earlier than we have done.
And what the reason for the choice of temsirolimus? Because
well, I mean, originally, of course, this was a European registration trial, and they had to do a randomised study. But the phase 2 was so good, the regulators accepted it. And so this is the confirmatory study.
I have a question because there were also trial Velcade, and Velcade have been FDA approved also, like temsirolimus was only EMA approved. And we heard about also Velcade trials today as a maintenance. You want to make some comment about the Dutch trial? Or?
There were 2 trials, weren't there? So there was an American one, which I don't know what you think, but I found a little bit confusing. So it was a chemotherapy backbone.
Let's say it was confusing. Yeah.
Okay. So
we
both believe it was confusing.
Yeah, right.
So it's a chemotherapy backbone, and then a choice of Velcade as maintenance or consolidation. So 2 different ways of giving Velcade, and of course, because you had no comparator, you didn't really know.
Make an historical comparator.
A historical comparator. So that doesn't make any sense because historical comparators are always worse. Yeah. So I wasn't sure what to make of that. But then thankfully our Dutch colleagues did the right trial and did a randomised trial of no maintenance versus maintenance. which show no benefit.
Yeah.
So I think overall, my take on that was Velcade in a maintenance setting doesn't add anything.
Yeah. But did you notice that only few patients were randomized? As far as I remember, started with a study with 115 patients, and then it grew down to at least 30 patients in each arm.
That's
so
right.
it looks like the first part of the trial, the chemotherapy part with the autologous stem cell transplantation, was rather tough for the patient, with high dose of IRC, but very, very high dose of IRC.
Well, there's some quite tight parameters by which you were allowed to start the Velcade. So if your counts are a bit low, you weren't entering it. And some patients didn't want to go on trial, I think.
Yeah. I think so.
And the criticism that the Dutch people got at the podium was that the schema they used for maintenance, which was 1.3 once a week, I think, or once a fortnight, wasn't standard. There is no standard. So I thought that was
It was IV.
And it was IV, of course, So, I mean, subcut is what one would use now. But it just didn't seem to show anything, did it?
Yeah. So I think your presentation today was an important presentation for the mantle cell lymphoma world, the landscape, because you really demonstrate and confirm also that the Ibrutinib at relapse provide very long response as compared to temsirolimus. Velcade doesn't show any benefits in maintenance. So it looks like Ibrutinib is, as we all expect, a very important molecule in mantle cell.
I think the big surprise was that analysis on PFS by line of therapy. That both surprised and reassured me. Of course, the other thing that's been presented here, which we could just touch on, of course, one BTK inhibitor is good. Obviously, there are competitors.
Yeah, this was a question I wanted to ask you. And, we have one BTK inhibitor, but there are a lot of others now.
There are. And like you, we've trialled other ones, and so at the meeting is a Chinese BTK inhibitor from BeiGene, who are based in Beijing.
Sounds logic.
It's true, which looks very similar to the other second generation, the Acerta compound and the Ono compound. So active, clearly active, and well tolerated. So I mean, I think it's a good place. I mean, having a competitive landscape.
Yeah, it's good.
Whether they're any better than Ibrutinib, they may have a slightly different side effect profile, maybe slightly less bruising and bleeding, whether that's and cardiac toxicity. Although they're only very early on, so with longer exposure, these things might be similar. But I think having more than one drug, if they can get them licensed, will inevitably push the prices down, which will be good for patients because they'll be able to get access to these drugs.
So Ibrutinib monotherapy, you think, is the future? Of course.
So who knows? I mean, as you know, I'm a big fan of taking things away. So, instead of chemotherapy, rather than continually add it to chemotherapy. So there are two different approaches there. And I think, particularly in elderly patients, why introduce additional toxicity when you've got a drug that's so good? But
it's also a way to prevent from the emergence of resistance or subclone. When you put the pressure on only one target, you take the risk to see cells that are not dependent on this target to take the lead and then to see a more aggressive disease. I mean, that's theoretical. We have seen nothing about this at ASH. We are just making speculation about these things. So maybe that this combo with this new target, whatever we call it, chemo-free or whatever, could make sense, I think so.
I mean, just for the audience, Steve and I have got a trial that is a combination of Ibrutinib, ABT-199 and GA101, exploring just as you were saying, trying different ways to kill the cells. I think in relapse that probably makes a lot of sense. Up front, who knows? I mean, and it's patient group dependent, I guess. For elderly patients, you want to do maybe add as little as possible to Ibrutinib. For younger patients, you want to try and cure them. So combinations make a lot of sense.
Yeah, I think so. We in mantle cell, we really have a lot of new drug to test, but I think it's important to run trials to be sure that what we observe is the reality and not something that we want to see. And I think it's important to have still this phase 3, maybe phase 2, because there are not so many patients. So this year at ASH, I think we have the confirmation of the Ibrutinib, even if we have not so many doubts. But if we make some speculation about next year, what will be for you what should be waiting for ASH 2016?
Well, I think we're going to have longer follow-up in the studies we've been discussing. We're going to have the first combination data, I guess. We might see more with these novel agents. I think the trials you and I are involved with, maybe not next year, maybe the year after that. But I think for clinicians, it's a very exciting time because we've got a lot of tools now. I mean, 10 years ago, we're sitting here, we're talking about anthracyclines, yes or no, you know, or
Yeah.
rituximab, yes or no. Now we've got all these other things.
Or chlorambucil.
Chlorambucil. But you know, the other thing is we've got to be smart about how we do the trials, haven't we? You know, we can't do massive trials that take 7-8 years to recruit because of all these drugs. We've got to do quick studies.
Yeah, it's unbelievable of quick.
Yeah.
Things,
so we have to think.
fast as things change.
So we have to think of a different way of doing these things. It's an exciting time for patients, you know. And if you go into trials today, you have a possibility of getting some very exciting drugs.
Yeah, I agree.
Okay, thank you very much. Next year we'll be talking about combinations for sure.